Hi, I'm Dr. Mylan Kohler. I did my training at Stony Brook University Hospital in New York, both for adult psychiatry as well as the Child and Adolescent Fellowship. I've been in practice here in the Manitowoc area for the past 4.5 years now. It's been a while. So I was asked to speak tonight about medications and autism, and at first I was going to do a handout. But there'd be very little information on it, so I decided just to make it more informational and to field questions. Because right now there are actually only 2 medications that are FDA approved to treat irritability in autism. Risperdal and Abilify. That's it. And it's specifically only for irritability in autism. There is no medication treatment for the core features of autism. Core features being the problems with social interactions, the rigidity that kids can have, the stereotypical behaviors that they can have, poor eye contact, things like that. There is no medication treatment to address that specifically. It's going to be different behavioral modification type treatments. So ABA is probably one of the most well studied for that. So that part isn't me that I usually refer to, and I brought a few handouts here, at least for those who are here tonight, that the pediatrics department has put together with a lot of the area resources, as well as a little bit of an overview about what might be available and what these things are for someone who has no idea. That being said, yes, there's only 2 things that are FDA approved. The thing is, with child psychiatry, most of what I work with is what's called off-label, meaning FDA doesn't exactly say, I can use this, but it gets used anyway, and it can be studied that way, depending on what it is that we're specifically targeting. And it's not just psychiatry in general that does that. Any medical field can do that. If it's out there, it's been studied for a specific purpose, but oftentimes there would be smaller scale studies that would look for a particular thing. So like Risperdal and Abilify, they were not originally developed to treat autism. They're antipsychotics. They were originally developed to be treatments for psychosis, which is not the same thing as violence like in movies. The real thing is a disconnect with reality. There are going to be hallucinations, there's delusional thinking. That just doesn't make for good TV, quite honestly. So don't go to TV for what it looks like. But these medications also have a lot of other uses that they've found over time, where they get used as mood stabilizers, they are studied for aggression in children, they're studied as adjunctive medications for antidepressants if they're not working as well. A lot of times I joke with parents, gee, what don't I use Abilify for? That would be ADHD, by the way, because it does nothing for attention. But it does help with a lot of other things because it does help reduce a lot of the intrusive, repetitive type thinking. It can reduce repetitive behaviors. It's not known exactly why, but that is something that does happen. And it does seem to decrease the irritability and aggression that a lot of kids can have. So that's kind of extrapolated out from a lot of those other studies. And the same thing goes with anything else that we might use. I say we, but in general for me, it depends on what I'm seeing in the office, what I'm hearing from parents as to the particular groups of symptoms that are problematic. Because there are plenty of kids who have autism, teenagers with autism, adults, who aren't on any medication. It really depends on if there are impairments in their ability to function in some area. If there's no problem, there's no need to add medication for it, basically. So a lot of times it comes down to, are they having trouble with school? Are they more inattentive? Are they really hyper? Are they bouncing off the walls or literally trying to climb the wall when there's nothing there? I've seen that. So if that's the case, we address the more hyperactive, inattentive symptoms the same way you would treat ADHD. So it would be stimulants, non-stimulants that we would do. If they seem to be more anxious, they have more repetitive behaviors that appear very OCD-ish. And I say appear because that is one of the core features of autism, but if it's causing them distress, that's when we would say, okay, maybe we need to address this. And so if we treat it as if it's OCD, that's going to be the antidepressants. Antidepressants are also anti-anxiety agents, and OCD is one of those things that it's been reclassified in the DSM-5 as an impulse control spectrum disorder, but it also is very much tied to anxiety. And the anti-anxiety medications will treat the OCD. There are actual small-scale studies of antidepressants being used in adults with autism to see if it will reduce some of the irritability and core features with that. They're small-scale studies. They look like they might be helpful. It would be more helpful to have a wider range of people that are in these studies, but we have to work with what we have. It costs a lot of money for these studies to be done, and let's face it, most of the antidepressants are generic. There's no money in it for the drug companies to put into doing one of these studies. So we're not going to see something huge unless it's a brand new medication that's going to be on patent for the next 10 years and they can make their money back. Might be a little bit pessimistic of me to say so, but that does seem to be kind of the issue. With aggression, it's going to be the same thing. We've got the Risperdal, we've got the Abilify for the irritability in autism, but not everybody can tolerate that. They do have side effects. So a lot of times it'll be other medications in the antipsychotic class, mood stabilizers, so that would be like Depakote, lithium. I've actually used what are technically blood pressure medications, actually. Clonidine and guanfacine are technically blood pressure medications. They have been studied as treatments for ADHD, as non-stimulants. I've used them in some kids to try to reduce the aggressive impulses. Propranolol is a blood pressure medication. Gets used for performance anxiety and things like that. There are some small-scale studies that show that it decreases irritability and aggression and impulse control issues. Depakote, that's anti-seizure medication, also a mood stabilizer. Some studies not so good in terms of straight-up aggression, but a lot of times it can be helpful too, and especially I've had a couple kids where they seem to behave as if they're in pain. And when there's a family history of migraines, it's okay, they're not verbal enough to tell me if they're in pain because it's a migraine, but they don't want to be in a brightly lit room, they don't want people touching them, you have a history of migraines, let's see if this helps. You know, it's trying to treat what the underlying issues are. And I try to be very upfront with parents. It's okay, we don't know if this is going to work very well. We're not going to be able to get everything. But what are the parts of what's going on that we can possibly reduce the issues with so that they can function better, so that they're not in as much distress? That's really what the key is. Are they able to function in some kind of school setting? Are they having these ginormous meltdowns at home where they're beating up everybody? Yes, okay, we need to do something about that. We need to maintain safety. If they're not doing that, you don't need to see me. We have to be very practical about it. So that's kind of the approach that I take if somebody comes to see me in my office. It's going to be very piecemeal, and it's really going to vary from one person to another because it is a spectrum. There's going to be kids that are very obviously autistic in the sense that they are nonverbal, they don't make eye contact, they might be rocking or grunting or things like that. And if they just don't have that understanding, they're in my office mostly because that leads to aggression, the irritability, the acting out, and people getting hurt. All the way to someone who they've had enough of the social skills training where they know they can fake the eye contact and they can fake the reciprocity in relationships. They still feel weird about it. But maybe something about that is causing distress because they feel that weird, it's causing depression or anxiety. We treat the depression or anxiety. Can't treat the autism spectrum because that's just how their brain is wired. But we can treat the other things that it might be causing. So that's the approach that I try to take with that.
Is there an age that is too young to be put on some of these medications? Or is that too general?
No, it's most of them, they have not studied below age 5. Stimulants have been, actually. There are pediatric trials for stimulants. So preschoolers, there's data out there for preschoolers with stimulants. For like the antipsychotics, for antidepressants, the blood pressure medications, I don't think there's any studies below age 5 or 6. And considering that a lot of the kids with autism have like Title 19 or MA and things like that, there are additional loopholes that you have to kind of go through in terms of blood testing and things like that below age 7. So they really frown upon you using a lot of medications. And that really shouldn't be the first step anyway.
Are there any differences with somebody with autism with their neurology, so to speak, with physiology, neurology, of how they process some of these medications, or is it pretty neurotypical?
That's actually, it depends on the type of medication. In case you can't hear that over the video, the question was, is there a difference between someone with autism and someone neurotypical in how they process medications? It depends on the medication type. Because some people who are on the spectrum, they're actually more sensitive to particular types of medication. The benzodiazepines, that's one type of anti-anxiety medication. So things like Xanax, Ativan, Klonopin. Sometimes that actually activates them. Instead of calming them down and they're less anxious, they get a little bit more agitated, more irritable. They look like they're hopped up and they're ready to go put their fist through a wall. That's a little on the severe end, but sometimes they have that response, and so you want to go pretty gently with that. On the other hand, there are some who are more sensitive to medications than you would expect. So they need to be on really itty-bitty baby doses, even though they're a big burly adult. And others, throw it at them. It's okay. They can get these huge chunky sized doses and it has what looks like no effect. A lot of that is probably more to do with their own enzyme activity levels in terms of their liver enzymes, as opposed to being on the spectrum itself. But because there's plenty of people who have reactions like that who are not on the spectrum. But a lot of it also has to do with how they understand what's going on too. Because if they have no real concept of the social aspect of things and they're not anxious about it, they're not going to notice if they're on something or not. Questions?
Do you see anything, typically, and we were talking earlier, that sometimes parents come, people will say, well, it's bipolar and autism, or do you see a lot of co-occurring things happening?
Should I repeat the question? Did you hear it?
Sorry.
Okay. The question was having to do with co-occurring diagnoses, like someone who comes in who might say, okay, they're on the spectrum, but they also have bipolar tendencies or things like that. Or what I hear a lot is, oh, they might have a little bit of ADHD. A lot of that has to do with the fact that it is such a broad spectrum and that there's no one prototypical autistic kid, and that there's no definitive test for any psychiatric diagnosis. It's that there is a lot of overlap between one diagnosis and the next. And so with the autism spectrum, it's how it's defined. The way it used to be defined with DSM-4, you could not be on the spectrum and have ADHD. It was part of the diagnosis. Does not have ADHD was literally part of the diagnosis in DSM-4. DSM-5, they removed that. So now you can, because there was enough research out there and people were seeing it up and down. Yes, you have kids who are autistic and they have ADHD, that they have both, that they are distinctly different because they've got that rigidity in the social aspects of things, and they've got their set way of doing things, and they have these horrible, horrible meltdowns when the number on their bus is different from their usual bus. You're thinking, it's the same bus, it's the same driver. No, it's a different number, and that was enough to make one of my patients freak out. But at the same time, they also have a lot of the classical symptoms of ADHD. where they're not able to focus, they're not getting their stuff done, they're hyperactive, they're fidgety, and this happens regardless of whether their IQ is on the higher end or on the lower end. They can co-occur because it's all a question of the genetics. All of these things are very highly genetic. A lot of the studies they're showing at least 60–70% of the risk involved has to deal with family inheritance. So you can have that at the same time. Same thing with bipolar disorder. And over at Stony Brook, we're in the more classical definition for kids. There's another group in the research. There's a little bit of controversy in the child psychiatry fields with a little bit softer what qualifies as bipolar disorder, in the research at least. So there's one group and then there's another group. And I was trained in the more tightly defined group. So you want to have the classical, here's a manic episode, here's a normal, here's a depressive episode. But you can see classic adult-sized bipolar disorder in a little itty-bitty pint-sized child, and they're still on the spectrum too, because it all goes based on symptoms. And if we had any kind of specific test, which if you look at the research, they're trying to develop those kinds of things to identify the genes, there is a lot of overlap between all of these things. There are a lot of the same gene sections that seem to be indicated, not just in mood disorders or ADHD, but also in autism itself. Like there's new research that's coming out that shows not only are there environmental triggers, it looks like that there are some genes that seem to be in common, and there are brain abnormalities in utero that can be determined that shows that, yeah, these kids are the ones that turn out on the spectrum later. So.
About how many kids in your practice have autism?
Oh, I should have actually done a tally. I mean, I have a list of who my current patients are. I have about 560 now, because I keep a list. But I keep a track of what they have. I don't know how many kids are with autism. It's not a high percentage, though. Because again, a lot of this is not treatable necessarily with medications. So I have far more ADHD or depression or bipolar or anxiety than I would autism. If I had to guess offhand, maybe 10%. But then 10%, okay, I know I have 560 on my active list, that's 56 right there potentially, if I had to ballpark it. And none of them are on the same thing. They're all in different things.
And most of them are dual?
A lot of them, yeah. Because they have autism, they may have ADHD as well, they may have depression or anxiety as well. I got one who actually has autism spectrum, ADHD, OCD, PTSD, and separation anxiety. I just saw her this morning, as a matter of fact. And she's one of those that are super sensitive and can't take anything for certain things. So all of the antipsychotics can't take. All of the treatments for ADHD, allergic or nasty side effects, so can't address it with medication. And this is all strictly defined. It's not just messing around with it. It's like she meets all the criteria for these things. So I try to do that with kids, and it's tough.
What would you say, like, would be your criteria to say, like, because I have son with autism, and I think he's suffering from really bad anxiety, but I don't know if that's just, like, what would you say would be, like, some symptoms that maybe I should, like, maybe for him to come see someone like you? Like, I mean, what would be, like...
Well, there's a lot of different labels that we use for anxiety disorder. So if it's more of a generalized anxiety disorder, anything and everything will get him worrying. That he's tense all the time. He looks like something bad is about to happen. Or he might not say that there's one particular thing that gets him worried. Like some kids are afraid of storms or the dark. And you can definitively say, okay, that's a phobia, which is an anxiety disorder. But it's everything. Just he's nervous. He doesn't know why. Everything, just anything that can possibly go wrong will go wrong. That not even 10% risk of something bad happening is going to happen, 100%, absolutely. Physically, you will feel tense, and nervous, heart racing all the time, can't sleep very well, thoughts are going in circles over and over and over, especially about all these horrible, terrible things that are definitely going to happen.
Yeah.
Well, he'll talk very fast like this because he's got to get it out.
He's not that verbal, but he looks tense all the time. I mean, I feel bad for him because his whole life is like this.
Right, and if they're not very verbal, you have to go on behavior. And so the behavioral kind of things that you'll see for people that are very, very anxious is they kind of look like they're like this all the time, and they're constantly looking like they're scanning for threat, where they're very hypersensitive to things. They're on the alert all the time, that they just don't seem happy. And not that they're sad and crying, but just they don't have that enjoyment of things because they're too busy worrying what's happening next. What is this bad, terrible thing that's happening next? So you pick it up more in the behavior, that even stuff that they like, there's something missing. They're just not enjoying it quite the same way. They're not as into it. They're not present.
Would
more
repetitive
distracted.
talking be part of that, or like the echolalia or anything like that? Does that go with the anxiety piece or not really?
Not really. The echolalia.
Because that can come off anxious sometimes if they're always repetitive and saying the same thing over and over.
Like if it's almost a ritual type thing, but that's not necessarily anxiety.
But if it's paired with like the
if it's
tension.
paired with something else, then you can tie it together. But if it's
Okay.
just on their own, because a lot of times kids on the spectrum, they'll repeat entire pieces of movies and songs and things over and over and over and please no, please just no. I've
So
heard
for
this the first 1,000
example,
times.
like let's say a parent goes out of the room and they're tense and they're, mom's in the other
Right.
room, mom's there,
So-
mom's here, mom, they
Like
have to
if-
know.
you would have to see it as if they were more of the nonverbal kind of toddler thing, that they just look like,
Okay.
Where'd mom go? Where'd mom go? Without the verbs, but they're looking constantly to see what's going on. And then when mom comes back, you can see that there's the relaxation in their body language. They don't have the words, but their body tells you the story. You can see it physically with that.
He does say, where'd mom go, where'd mom go, where'd mom go,
And a lot
crazy
of
about the
times,
lights.
yeah, a lot of times it's not that that having the autism means that they have to have the anxiety or they have to have the depression. A lot of times that seems to come in more with the teenagers that have it when they're socially aware enough to know there's something different about them. If they're not socially aware, okay, whatever, then they can go off and do their own thing and they can hang out and talk Pokemon and Thomas the Train all day long until everybody else runs screaming from the room, but they're happy because that's what they're into. And if they're not socially aware enough to realize that other people have run screaming from their room, they're okay, they're not anxious, they're not depressed, they don't think there's something wrong with me. They think there's something wrong with you. But if they're socially aware enough to realize, oh wait, they're not wanting to listen, they're leaving. Why are they leaving? Why aren't they staying with me? Why aren't they my friend? That's what that can trigger the depression cycle because they're aware enough to realize, okay, this is not right. All you guys over there are hanging out together and talking and laughing and having a good time, and nobody's hanging out with me. That's what seems to set it off in teenagers, when they're socially aware enough to know what's different, but not how to fix it. And that's not always me involved either. A lot of times that's me involved once the therapist is doing their bit with trying to teach social skills and anger management and how to do the relaxation exercises and doing the social stories. Okay, here's the script of what you need to do in this particular situation. But if that's not helping enough, that's where sometimes I get the referral from the therapist saying, we're working on this, but it's just not helping enough. They're still very, very anxious, or they're still very depressed, or God forbid, they're suicidal now. And we need to do that in conjunction with the therapy. The best response is not me alone. It's me with the therapist involved, with a lot of other services involved.
So if you're a parent who thinks they need your help, how do they go about?
Usually that comes down to talking with the pediatricians. I think there's something going on. I think I might need to see a psychiatrist. What do you think? Usually they say, yeah, here, go.
Yeah.
Because they realize that there's only so much that they can do too. And most insurance companies, they work that way. They want a gatekeeper because psychiatry is one of those weird fields. It's a specialty, yet not. So sometimes with insurance companies, you can do a self-referral and just call your insurance company and say, who's in my plan, who takes the insurance, and hope that it's not a 6-month wait list. And other times, no, they want you to go see like a primary care, pediatrician, something like that to get the referral. Because then in that particular network, I would count as a specialist. So it kind of goes for those different ways. Therapists, usually you call the insurance company, see who's in your network that takes your insurance, and hope you get in soon.
So would an intermediate be, like you're saying, pediatrician, would a pediatrician go to a psychologist, before sending to a psychiatrist?
Usually, yes.
Okay.
Yes. It's usually to, like, especially if they're young enough, birth to 3 would be one of the first interventions. They might do the referral to Dr. Iden to do the ADOS and get the definitive reference to see where the skills are, where they're not. It's usually the therapist first. But usually it's you need a psychiatrist if it comes down to there's that physical threat. There's they're aggressive, they're banging holes in walls, they're beating up on people, pulling out hair, that they are depressed and suicidal. That's when they kind of skip over that and go to me. It's the severity of the situation.
What do you do with situations when there's a big discrepancy between behavior at school and behavior at home? And it can go either way. How do you handle it psychiatrically?
Did you hear that over there?
Very quiet.
Oh, okay. So the question was, how do I handle if there's a big difference between behavior at school and behavior at home? Which happens a lot. I wonder why. But a lot of it has to do with how kids respond better, because it has to do with most of the kids, and this is in general, not just for kids on the spectrum, but kids in general respond better to structure. And especially at home, there are a lot of parents that, they can dream about structure, it's not happening. And then there's others who do everything that they need to do. They've got a behavior plan, they're on top of things, they're correcting every single time something happens, and things like that. And some of it also has to do with how well the parents respond. Where's the match? Because it can change from year to year, even with school. There might be one teacher that responds really well with a child, they just click. And the following year, it's a new teacher, it's just, the demeanor's a little bit different, their understanding might not be there, and the kid's like, I hate school, and we'll have a tantrum every morning. And at other points, it might be that maybe there's one parent who really gets it and really clicks with their child and can do all that stuff, and another one who's maybe the softer parent, doesn't discipline as consistently. Is but I think they've had enough, or they did really well with like the in-home therapy, and they're really tired, and well, give them a treat. No! If they're throwing things across the room, no, you don't give them a treat for that. I'm sorry, I see a lot of pointing fingers around the table. You just can't do that. But you really shouldn't do that with kids that are not on the spectrum either, but especially for one that is on the spectrum. They're so rigid in their thinking. The term for it is concrete. It's a very early, simplistic kind of thinking that very young kids have. This is the way it is because this is the way it is. They don't get figures of speech. They don't understand the nuances in all of those. It's black or white. What do you mean gray? There's no such thing as gray. No, this is the way it is. This is the routine. So when I mentioned before how some kids, they almost feel like it's scripted, like when they're learning the social skills, because that's what it is to them. When I was studying at one point, I heard a beautiful way of describing it, is that like when you're learning how to dance, you have to think of each step in order, and you're kind of wooded and clunky because you haven't really learned it, you don't feel the dance yet. And then as you go, it's more comfortable, it's more natural, it's something that you don't even have to think about anymore. Autistic kids, they don't get that part. It's constantly this step, then this step, then this step, then this step. It's constantly a script. So they don't get that fluidity in the interactions. So they need that consistency. They need that to be repeated over and over and over. These are the rules. You don't deviate from the rules, because if you deviate from the rules, oh, that's a new rule. You just undid everything.
So it sounds like if you have a lot of repetition and practice, then it becomes more routine for
Absolutely.
autistic or neurotypical.
Yeah, it's the repetition. You know, it works for neurotypical too, but neuroatypical, they absolutely need that. You need the stability. Chaos is not your friend. So it really comes down to what that particular child responds best to. It's usually comes down to the repetition, the structure type, and just how well the interpersonal response is.
How often do you see that a child or a family will come in and you find the right thing right away? Like how, you know, what is the time span that usually takes to truly get, you know? I'm rewording. Hey, I'm trying to find a question other people might like to hear.
Oh, it's very much trial and error, unfortunately. I wish I could look at somebody and know what works. It's really good if it's first, second, or third try and getting something right, but a lot of times it's not. That we have to try a bunch of different things.
I think that's important for families to hear. You know, it is something that takes time.
And it's not just for it's for anything. It's like that for any disorder. It's not just on the spectrum. But it's even more frustrating sometimes for parents of kids who are on the spectrum because they've got these massive issues. I mean, I don't want to call them deficits. I don't want to say problems because there's nothing wrong with these kids. You know, they just don't fit the way society is. There's nothing wrong with them. They're fine. If we can just try to find the best match for them. Because if we find what works for them, a lot of times, you don't need me. It's okay, you can be off medications if we find the situation that works for you. You know, there's the kind of joke is that all of Silicon Valley has Asperger's. You find something where you fit. And it's easier to do that as an adult than as a child. Childhood's rough, even for kids that are not on the spectrum. So it's if you find that niche, and it doesn't come right away. And it's like that with medication, it's like that with therapists, it's like that with any of the treatments that are out there to try and teach the social skills. No one particular approach is the best one. They're ones that have the most research, they might have the most funding, things like that have more people that know how to do it. But it's as much figuring out where an individual's strengths are and playing those as best as you can. And really trying to bolster where their weaknesses are.
When you have a child on medication, is there like, I'm gonna try and think of how I'm gonna say it, but.
You don't have to be polite with me.
No, well, my daughter has been on Depakote for like 2 years. Is there like a possibility that she could like be immune to it and won't work anymore? I mean, she's on it for anti-seizure actually, but because she's got autism also, would it help that? I mean, not because she's got really bad emotions.
Well, in the case of your daughter, she's got the Depakote for the seizures. Right. So.
But could it be like immune to that eventually, where she can have a breakthrough seizure or?
Oh yeah, there are some kids after. There's no set number of years where medications don't seem to work as well, and especially with kids, it might be after a couple of years because they're growing, their enzyme activity levels are changing, their metabolism.
So you just really never know what med.
So that's why you're constantly checking in to make sure things are still working the way they should be. So you might go a couple of years where the visits are, yeah, everything's great, we're good, see ya. And then it comes down to, oh my God, there was a breakthrough seizure. She was so much more emotional. She had this massive meltdown. It came out of nowhere. I have no idea what was going on. Things were great up until and it can be almost like out of nowhere. But then looking back more carefully, you might have seen a very slow slide, in which case then it's more of the metabolism, because things change over time for kids. Their enzyme activity is super wicked fast when they're very, very young. and it starts slowing down a little bit as they get older, as they get into their teen years, as they get to adults, it stabilizes a little bit. When they're older, then it slows down again. So different stages of life, the dosing would have to be changed, just to make sure that it stays on track for what you're using it for. But sometimes every few years, you might have to change things completely. It's notorious for that with the SSRIs, the antidepressants, because some of those, they just don't work anymore. Very colloquially, I'll tell people, yeah, they just poop out. They just don't work. That you can try them again later, and maybe you get a little bit of a response. Like an adult with depression, where we've done this, she's been on just about every single SSRI out there and SNRI. After about 3 or 4 years, the doses have to be up, or we have to switch to something else if she's already at max. And we retried a different one that she's on. I mean, not all of it was with me, obviously, I've only been here 4 years. But this is her history since her teenage years. That every few years it has to be switched. And trying to switch back to something she's been on in the past only got 2 years out of it, instead of 4 or 5. So some medications are known to do that more than others.
In a presentation that Temple Grandin gave a few years ago in Green Bay, she was, 2 different things. One was, I guess, the overdose of a certain drug they might be taking for autism. And another would be, let's say they're taking 5 different things, like your friend with separation anxiety, autism, bipolar, and that, and trying to find some happy medium. She said sometimes that can be very difficult.
It is. I mean, it's what you have to be very careful about trying to make sure you've got everything as best as you can, which changes all the time with kids anyway. But knowing somebody has this, whatever diagnoses, I try to pick something that will target as much of that as possible, so that they're on as little medication as possible. So, I mean, the one that I saw this morning that has the 5 different diagnoses, I mean, entire classes of medication she can't take because she actually has QTC prolongation. So that's a whole separate medical issue that totally throws out entire groups of medication because she can't take them, period, cannot. So for someone else who doesn't have that QTC issue, that might have autism and depression, okay, well, the autism, we're not going to do that with medication necessarily, but the depression, we treat the depression. If it's depression, anxiety, things like that, we treat that. It may relieve some of the distress from the autism. It may wind up relieving some of the repetitive behaviors a little bit. It's not going to suddenly make them not autistic, but you try to get the most symptom clusters as you can with the least amount of medication. And when it comes down to it with the psychiatrist, there's like maybe 6 classes of medication we have to choose from. So we do a lot with what we've got, which is where a lot of the multiple uses of things comes into. And a lot of times the multiple uses have to do with the dose. Smaller doses of something would treat one particular type of issue, larger doses would treat something different.
There's a term med wash that I've heard where kids go to a hospital, wherever, and they take them off everything, I'm assuming. I don't know.
Sorry.
What is that about?
I kind of laugh because, yeah, the med wash in a hospital, yeah, that doesn't exist anymore.
Oh, it doesn't?
No. Hospitals at this point, they have their place, but they're more like glorified emergency rooms than anything else. They go to a hospital if they've got some sort of serious issue. They're suicidal, they're homicidal, they're actively psychotic, there's a safety issue, there's a risk that cannot be assumed by family or local police or things like that. A med wash is basically trying to get everything out of the system. At this point, I've had some patients who were turned away from hospitals, literally, when they were asked, can we go inpatient to safely come off of whatever medications and start over from scratch? No, you're not acute enough. Like, they were literally turned away. So it has to be done as an outpatient. So that means it's much longer to try to come off this stuff. mostly because I know when I try to get people off of medication, I try to go very slowly, very carefully, so to minimize any discontinuation effects, which is basically the nice way of saying, yeah, they're withdrawing off medication for all practical purposes, because it feels awful suddenly cutting off of things. So we try to go very, very slowly, trying to set these kids up for success of really coming off of things. So, not necessarily for autism, but I had one child who absolutely, absolutely hated being on medication, didn't want to be on it anymore. But prior trials with someone before she came to see me, just the aggression came back, the mood started cycling rapidly. So she was on 2 milligrams of Risperdal as her mood stabilizer. We wound up going 1/4 milligram every month to 2 months. But going that way, she was off it. She's been off of it for 2 years now. So it has to do with also her being very on top of it, family being very on top of it, where she knows she can't just stay up all hours either, so it won't trigger mania. And she may run a little bit more active than her family sometimes may like, but she's not full-blown manic. And as long as everybody can handle it, we're okay. And I just saw her like at the beginning of the school year, and she's been off of everything. So it's possible. A lot of work, very slow, but it's possible.
What's your opinion on alternatives? Like a lot of families that are interested in other things besides medication, when people like that come in and they say, we'd like to try these different things, what's your approach? How do you handle that?
A lot of it depends on what it is that the issue is for. And I look into all of that stuff too in terms of, I'm sorry, the question was about alternative medications and medicines and alternative treatments for things. So it depends on what it is that they're looking for, because there is research out there now for multivitamins, like omega-3 fatty acids, SAM-E for depression, folate, B12, vitamin D, especially for seasonal depression, things like that. Some actually has a pretty good evidence base. Some, not so much. So there's more for anxiety, depression that shows that there's an actual effect from a lot of these complementary approaches. And ADHD, which I hear probably the most from parents who say, well, if I go dye-free or gluten-free, or if I do this or if I do that, I've told some parents, I said, if you want to take that approach, you can try that. I can tell you that the research shows nothing good. I can tell you that, but if you want to try that, I'm not here to force pills on people. I mean, I know I'm a psychiatrist, I talk about medications, that's where my training is, but the idea is not to throw pills at people and see what sticks. It may sound like that sometimes, but that's not the idea. The idea is to make it so that you're able to function. So if parents want to try the diet approach, you can try it. Maybe it'll work, but it seems to be that unless there's some sort of gluten sensitivity or a food allergy, or that, you know, maybe they have sleep apnea, you know, something like that that's correctable, it's not going to really do anything. You know, parents like that who are really anti-medication, I'm not here to make you take something or make your kid take something that you don't want them to have. If you don't want to take something, okay. Invariably they start coming back though, because the diets don't work unless they've got some of this other stuff, but that doesn't mean that it takes care of everything either.
But it sounds like you'll still work with them. Mm-hmm. Okay, because I've heard different doctors, different areas of the state, they could say, well, no, if you're going to try anything alternative, I won't work with you. So
I tell them, tell me what you're taking. And for teenagers, legal or illegal? Tell me what you're taking. I'm not going to call the cops, but I need to know what you're taking. And this just happened last week, where it's like, oh, that's why you had so much anxiety that didn't respond to medication. Oh, so withdrawing. Oh, yeah. Suddenly she feels so much better now that I'm treating the actual problem. Yes.
I'm not against medication and I'm not for medication. I'm one of those people that's right in the middle, look at everything and figure it out. And when you have it where your kids at that age where they decide on their own, despite how you try to tell them that it's not safe, when they decide to suddenly not take their medication because they are determined to figure out whether or not they really need it, and you do everything in your power to monitor them, and they're bigger than you, so there's only so much you can do for that, how can you explain to them that, and he's not against medication, he just every now and then wants to see how he'll be without it, and he always picks a school day. And then there's some meltdown. And we just had our biggest meltdown ever today where he tried to run away from home because he decided that this was happening and that school was too stressful and he just can't handle life anymore. How do you get through to them that, you know, this is one of the issues, you need to keep taking your medication. I mean, he sees how I am. If I miss any of my stuff, I get headaches, I start feeling sick to my stomach, I can't think straight. But that, him seeing me, isn't getting through to him. How do you do that with a kid that's 12?
And if he's on the spectrum?
He's on the spectrum and ADHD, and even though he's not had any medication for it, it has been documented for years that he's very high strung and has high anxiety. There's nothing for that at the time being. And I mean years. Since he was 7, they've documented high anxiety. But he doesn't take anything for it. No one ever gave him anything.
Because the autism part means that what he sees you go through, well, that doesn't apply to him because you're different. So,
he knows I have the same diagnosis as him. That doesn't matter though?
No, it doesn't matter. You're different.
Oh, okay.
The rules are different. You're a
Okay.
different person. Doesn't apply to him.
Okay.
So you kind of got that teenage part early.
Yeah, we went to the doctor. They said there's 5 stages of puberty for guys, and he's in stage 4. So, yeah. Yeah.
Yeah. But it comes down to very bluntly saying, okay, you have to go and very concretely say, okay, here's the evidence that we have so far. This happened, you take this medication, this is the good day at school. Don't take the medication, here's the meltdown that you have. This is what you did. Every single trial that you have,
he keeps
you list
thinking
it down.
that's going to change.
And what I have with some kids who are like that, because yeah, who wants to take pills if they don't have to, where they had all these meltdowns. For 1 or 2 of them, I've said, oh look, let's see what you're taking here. Oh look, this one comes as an injectable form. You don't want to take a pill? We have an injection for that.
He'd actually be happy about that.
There are some kids where they don't want the pill. And not just for kids on the spectrum. I mean, I have 3 teenagers who are on an injectable form of their mood stabilizer. Totally off-label. Because Abilify has a monthly injection and it's marketed for schizophrenia. But it's still Abilify.
Yeah.
And they did great on Abilify for their mood. But they just don't take it. They do great when they're taking it. They know they do great when they're taking it. But they just don't like taking a pill. Well, Abilify has a melting form if you don't like pills, because if it's a sensory issue for the autism, well, there's a melting form.
No, that's not the problem for him. He
just doesn't want to take it.
So the funny thing is he'll still take his allergy pill. He'll still take his melatonin at night. It's just this one pill in the morning, and he's been taking ADHD meds for almost 7 years, and just all of a sudden out of nowhere.
It's the ADHD one.
Yeah, that's what it is. It's the ADHD one. He'll take his other stuff.
Okay, because for like the mood stabilizer, for the antipsychotics, some of those have injectables. So I've had some who go, yeah, gimme, because they don't want to take a pill, and they're okay with that. And I've had one kid look at me in horror and goes, I don't like needles. He's like, then take the pills.
Yeah,
he's taking his medication now.
He'd take a needle over a pill, though.
But for the ADHD, depending on what it is, there are different types of things out there. There's Vyvanse.
That's what he's on.
Oh, you can break that open and you can mix it in water. The powder actually dissolves into water, or you can put
And it's still going to be time release?
Yes.
Okay.
It's because of the type of medication it is. It's List dexamphetamine. The body has to metabolize the List part off to get the dexamphetamine, which is a stimulant. That's what makes it long lasting.
Okay.
So you can mix that in water. It's water soluble. So water, if he thinks it tastes nasty, apple juice will work, cranberry juice. Try not the, I usually say not orange juice because it's a little too acidic.
Okay.
So it makes it release a little bit too soon.
Okay.
But you can mix it in water. You can put it in applesauce, in
Kool-Aid.
Kool-Aid will work, ice cream, yogurt, something soft. For some kids it's a texture thing, some they just don't like the idea of medication, but oh wait, I get a scoop of ice cream in the morning? Sign me up. So you treat it as if you just can't swallow. And
Okay.
Vyvanse is really easy because you can mix that in his drink.
Yeah, and he has no problem with his afternoon meds for his ADHD because he burns through the Vyvanse, his metabolism's so high. He has no problem with the 3 o'clock dose, it's the morning dose.
Yeah, they say it goes for 14 hours, but not in kids.
No, his lasts 5.
Wow.
5 or 6 hours, that's it.
Wow.
Yeah.
Yeah.
Yeah, at 3 o'clock, he needs something. He's just all over.
Mm-hmm.
Tina, if it helps, we started that with Alex because he wasn't taking meds and refused to take meds. It worked with him. We did applesauce. We did soft foods with him
Okay.
because he couldn't swallow the pills either.
Yeah, he can swallow. You could give him 5 pills at once. He can swallow it all at once. He has no problem.
It's
It's
the idea of it, or maybe
It's-
it's
yeah.
because it's a capsule and not a tablet.
well, the capsule he's had for a while. So I just can't understand.
Yeah.
Like and I ask him questions. I'm trying to see where he's coming from. And I told him, I'm like, I am not trying to argue with you. I'm trying to see where you're coming from so that I can understand, so I can answer whatever's going on in your head so that you can understand why
Or
it's
maybe you
important.
overheard how a stimulant is one of those things where you can take it or not and there's no withdrawal effects.
Maybe I
And
should
that's
just give him the side effect stuff that comes with the meds and let him read it or something. I don't know.
For some kids that's actually not a good idea because suddenly they'll have everything on that list.
Oh no, I just cut out. No, I just cut out the one section about if you suddenly stop. You know, it's just the little thing. Yeah, he would do that. Yeah.
In that
I don't know.
situation,
Very tiny type.
Yeah.
in that situation, you were talking about having the child see what happened to themselves, you know, once they don't take the meds. With a child with autism, would that help to have it black and white? You didn't take
What
it,
I've noticed
and this happened, you know, school was horrible.
That's what I've noticed, at least with the kids that I treat there on the spectrum. It's well, you look at it like an experiment, okay? Here's the day that you took it, you had a better day. We won't say good because, let's face it, some days just are awful no matter if you're on medication or not. But let's look at it the day that you missed your medication. What happened that day? Everything went wrong. Okay, you went back on your medication. Things were better again. You can handle it. Okay, things were going well for a while. You thought you didn't need it anymore. You stopped it. What happened then? Everything went wrong again. Okay, this happened twice now. What do you think are the odds this is going to happen again? If they say, well, I think I can do it. Okay, look at the evidence we have so far.
And it's good to have it written for them?
If they need it written, or if they just need to go step by step by step. They're very logic-based, if we have to generalize, because, again, that concreteness, black or white. So, this happens, then this happens. Straight correlation. So, a lot of times just pointing it out might help them understand where you're coming from. It's I don't want you to have this horrible meltdown. Therefore, you need the medication. And a lot of times it helps understanding what it is, why they stopped. You know, I have some people where they are afraid to come in because they think, it's almost like they think I'm going to yell at them in the office for not taking their medication. It's well, why did you stop it? And they look at me like, huh? Like they thought I was going to yell at them like a parent would. I was like, I'm not your parent. I'm your doctor. I need to know why you stopped it. Was it causing any horrible side effects? Well, I didn't like how I felt. What did you feel? I had headaches. Okay, I need to know this. They had a stomach ache. Okay, I need to know this. They broke out a rash. I really need to know this. You know, something like that. This is the stuff I need to know. And then when they say, okay, let's work with this. We know that this caused really nasty side effects, but it had some benefit. Okay, let's find something similar to that, but is different enough you won't have those nasty side effects, hopefully. And that's what I mean by it. Sometimes it takes a lot of different trials, regardless of what it is that we're treating. So, notoriously, like the antidepressants, they might say, well, this one made me have really nasty headaches. But I didn't feel as sad. Okay, let's try a different antidepressant in the same grouping. Because they're all different molecules, they shouldn't have the same side effect, but they do still work on the same aspect of your brain chemistry, it should have the same effect. So sometimes it takes 2 or 3 tries, but we get to it. It's just the frustration of having to go through it and feeling like a guinea pig.
So, we know somebody with autism, their brains, some of develop a little later than other people, neurotypicals do. With that in mind, and I think evidence is showing into the 30s and 40s changes can even happen. Can your level of autism change then?
Yes, but I say that as a qualified yes, because it's not necessarily the brain architecture that causes the changes over time, because your brain constantly remodels itself anyway, on or off the spectrum. That's called learning. The connections change as you learn, as you reinforce some connections, others get pruned away if you're not using it anymore. That's why everything is use it or lose it with our brains. But the thing is, if they're practicing certain skills, they're going to get better at it. They're doing social skills, they're getting reinforced for certain things that they do. They learn that, they get better at it. That's why there's that push for research to try and diagnose autism earlier and earlier, because the earlier you catch these kids, the sooner you can teach them these skills, the sooner they look like they grow out of it. I say look like for all these things, regardless of what the diagnosis is, because you're trying to change the behaviors, you're changing the way that they're interacting with the world. That underlying response is still going to be there. Their brain is still going to be wired that way. They're still going to have the connections that they had before, but they've modified it. They've changed their initial response. And not just for on the spectrum, but it's like training somebody with social anxiety to deal with that anxiety and give a talk in front of somebody. Not that I have social anxiety, but it's the same kind of thing. So if you can imagine that for somebody on the spectrum, you do the same thing for somebody, off the spectrum, you do that the same for somebody who's on the spectrum. You teach them the social skills, and then after a while they learn it. It's still going to be that rote, step by step by step. They're not a natural dancer, but they know the steps enough that they can at least go out on the floor. So that's what we can kind of get at.
What about medications and sensory? Is there any connection whatsoever that can be, that can help sensory processing disorders or issues, or do you just look at the hyperactivity with that? Their sensory.
The sensory stuff, that's an occupational therapy.
All therapies.
thing. That's all therapy. And that's what I mean by there are limitations to what we can get out with medication. We look at the symptom clusters. It's more sensory that are the issue. You have to go with occupational therapy to kind of work with those sensory issues and reintegrate that. And I have no idea how they do that. It's very long and it's very complicated.
So what do you do when you hit the medication and there's no longer any medications for what you're treating? What is your next step then? Where do you go?
Well, it depends on the symptoms that we're at. Like with the one that I mentioned that I saw this morning, yeah, we have no medications for ADHD that I can use with her at all. We've tried them all, literally, every single one, on and off label, every single one. None of them work. And that's not the only one. So then I'll say, look, okay, we can't treat this with medication. You're already trying to do some things at home. We have to tighten things up a lot harder now. There is no slacking off. And for this particular child, she's homeschooled. So it's even easier to try to do that, to modify her day so that she gets shorter chunks to deal with her attention span. So she can't do more than like 30, 40 minutes at a clip at her best. So she has to do 30 minutes of something, take a break, go to do another subject. Take a break, do another subject. Take a break, do another subject. It's very, very broken up, but it has to be done that way. She can't have any distractions around her, which means she's in a room by herself. Her siblings, who are also homeschooled in this particular case, have to be in a different room because them being there is too much of a distraction for her. So it just has to be completely that way, and it's just very, very, there is no room for error with that.
So basically, a schedule right to the T.
Absolutely.
No room in breathing.
Yeah, medication kind of helps make it easier to do stuff. It's not like it changes the underlying issue. The medication just makes it easier to focus. I tell parents all the time, this means you can do your homework. Doesn't mean you want to. I don't have anything for that. I'm sorry. But we don't have the medication to make that easier, so it has to be changing the environment. Because if you think about it, the medication changes the internal environment.
So if a child, let's say they have, in-home therapy, and they do really well when it's that tightly consistent and there's a routine and a schedule, and then they're good, but then if that schedule's thrown off, they still have those extreme tantrums and the rigidity is even worse.
Exactly.
Is your recommendation that because they're like that with the consistency, they really don't need to be on medication, or would you say maybe they still could benefit from
It kind of
medication?
depends, because I have a bunch of kids who they needed the medication to be able to pay attention during their therapy.
Okay.
So even though they, like I have one where he didn't need it throughout all of his school day because he had like the specials at the end of the day, and so with Jim he could run around and play and he was great. But then to have to sit there for 2 hours after school for his ABA therapy, and really they were on top of him constantly, he couldn't do it without medication.
Okay.
So it depends on the individual child's ability.
Okay.
But there are some who, yeah, if they're very, very tightly structured and there's no distractions, they don't need it.
Back to the medication question about if there's absolutely nothing left. But you also said that because the child's metabolism is changing, sometimes what you used a while ago might, except
Yeah,
for this
sometimes it can
particular.
be challenged. In this particular case, yeah, that didn't work.
Right, because
This particular
body.
case, it didn't work.
Right. But for a child who may have
In general, unless there were some sort of really nasty side effect, like since we're talking ADHD for this particular child, for ADHD in general, let's say they got more aggressive and angry and irritable on a particular type of stimulant. I'm not doing that again. Just flat out, no. That entire class, gone. Go to a different class of stimulant. If that's doing okay, but not great, we may adjust it. We may need to do a non-stimulant or switch to a non-stimulant, but the side effects are not worth trying again. Because I found that even when we've tried to do that again for some kids, thinking, okay, maybe they grew out of it, they were just too little last time, because, and this was seen in the pediatric trials, that the preschoolers, they have the same responses to medications as older kids. They're just more sensitive to the side effects and more likely to have side effects. But they have the same response. And it's that I've noticed every single time I've tried to retrial those, same response later. So, and especially if it's causing more irritability and aggression, not worth it.
Could it be the same for tics? I've got a guy now that has been off Adderall for a couple of years, and they've retrialed it. So far, so good, but it's only been a couple of weeks. But he had been on it for quite a while, his mom takes it. But he had developed tics the last time after a few years on the medication.
If they don't have a tic disorder, tics as a possible side effect can be dose related.
Okay.
So if he's at a much lower dose, and if he had no other side effects, then he should be okay on
And
it.
that was really effective of it, right?
Yeah.
He's much more happy. I mean, he was more compliant, he got through more routine better, all those things were better.
Right, but that's why I say that it has to do with if the side effects are the nasty, really, we don't want to see that again kind of thing. That's why it's if they're getting aggressive, if it's causing, like if someone has ADHD and bipolar disorder, if it's causing mood switching, no, we're not doing that. If they're allergic, oh, really no.
So is a tic then really not a nasty, because the mom was very concerned about that?
I mean, it depends on what the tic is, but as far as if we're going to rank them, tics, they're not that bad. They're annoying. They can, depending on what the tic is, it can be something that could be socially stigmatizing. But let's see, you have a tic, or you're aggressive. You have a tic, or you're aggressive.
Can you treat the tics?
You can treat the tics. They're very treatable. Not just with medication either, because yes, there's different medications to treat tics and they have side effects of their own, and that's a whole other issue. But even habit reversal therapy can kind of reinvent the tic into something else. So they are treatable, and a lot of times, especially when it's dose related, you can backtrack on the medication and then the tics go away. And sometimes because of side effects, you have to underdose what they would need to get at all of their attention, in this case for ADHD. But that's where the balance comes in. Okay, maybe they're more easily distracted than their peers are, but they're not ticking away and they're getting most of their stuff done, and they're still passing all their classes and getting most of their work done, and maybe they just need to be pushed a little bit. We're good. Because for them, that's not a good side effect. They don't want it. And I have some where we've tried that approach and it didn't work either. Not for tics, but because the appetite can really be suppressed with stimulants, where I've got one child, we tried less than, for him, Adderall 30. Works beautifully for all of his academic work, his behavior. He's very mild-mannered, even-tempered, does great with all of the family and stuff. But he doesn't want to eat lunch at all. Like, he'll have maybe a quarter of a sandwich. But when we tried less, suddenly he's getting write-ups at school. His parents are saying he's being nasty. He's not like physically aggressive or anything, but he's just talking back all the time. That's not him. And he's just looking unhappy and it's just argumentative all the time. So, okay, we have to just watch his weight and make sure he's eating the rest of the time when the stimulant wears off. So it depends on what the side effects are and how best we can manage them. So it really is finessing individual cases.
So now again, you said that if someone wanted to see you, they'd have to get a referral or check with the
Check with the insurance.
Okay.
Because sometimes they don't need one.
Okay.
Psychiatry's kind of weird that way. Sometimes it's a primary a specialty, sometimes it's a specialty.
But you have a waiting list for Medicaid?
Yes. Most places do. If they take them. Because there are a lot of places in Manitowoc County, and they don't take it at all. So.
And what do they have anything while they're waiting?
No, we don't have anything for waitlist. It kind of depends on the age, though. I was talking with Julie Engeldinger. She's our intake coordinator. I know they were putting together for adults like a coping skills group for those who wanted to be seen to address like depression or anxiety. I don't know if they're still doing that because not a lot of people wanted to do that. But it's one of the ways we try to get people to be seen in as timely a manner as possible. I know there is a wait list, and I think for me the turnaround time is not that long compared to some of the other practitioners in the county, but it still is a wait. And when somebody's freaking out, even waiting, I had this the other day, someone was not happy with a 6-week wait list. 6-week time for trying to get in to see me from the time that they called, and I think of the Aurora system, it's 5 months to see the psychologist for an intake, and then after that, they determine if you need to see the psychiatrist, and that could be another 4 months.
When my son was seen in the Aurora system, he got to see a therapist. We waited 8 weeks. This is a few years ago.
Mm-hmm.
And he knew that our wait to see the psychiatrist would be so long that he asked permission if he could talk with the pediatrician and if together they could figure things out. He's like, it's going to be a long wait. And I'm like, okay, sure. We didn't get to see the psychiatrist for a year. We were on the waiting list that long.
Wow.
I could have ended up waiting a whole year before he would have had treatment to focus in school and stuff. But since the therapist suggested working with the pediatrician, since the pediatrician was constantly studying and keeping up her knowledge on the meds, If we hadn't had that, and if we would have had a wait like that,
Yeah.
I don't know what I would
Because I
have
mean,
done.
it's not like I call up Aurora to see what their wait times are, but it's
Yeah,
just
but-
from somebody whose insurance changed and then they come see me after and they told me that that's what they had to do in order to
Mhm.
see somebody in the Aurora system.
Mm-hmm.
And I know at least within Holy Family, I talk with the pediatricians, like we email back and forth if there's anything, or they'll call me and say, hey, I have someone with this, that, and the other thing, and what can I do in the meantime? So I do curbsides a lot like that.
So you work through Holy Family?
Mhm.
Okay. My kids go to.
Oh, okay.
Like for pediatrics.
Oh, yeah. Yeah, I work with them all the time. So, yeah. Yeah, we used to be called Tamarack, now it's Holy Family Behavioral Health.
Oh, okay.
Yeah, they took us in the corner.
So I'm going to ask kind of a tough question from a parent point of view. Some of it's personal experience and some of it is what I'm hearing other parents say. Is sometimes what happens with kids on the spectrum is if they get pushed too far and they don't feel comfortable, they'll start making threats. And sometimes it's a behavioral problem, you know, or they'll threaten to hurt themselves. I've been in quite a few cases of that lately, where the kids are threatening to hurt themselves or others. And of course, the schools take those threats very seriously, which almost sometimes reinforces the behaviors. So is there anything from a medication point of view you can do for those?
Well, one, that's not special just for on the spectrum. Kids off the spectrum do the same thing. They know very quickly, and especially with all the attention for the anti-bullying policies and things like that that are out there, they know if they say, well, I'm going to bring guns to school, automatic suspension, out of school 3 days, they don't have to go to school. So they know that a lot of times. And especially stuff that gets played up in the media, because it's never anything good on the news having to do with any of this. So of course, they play up the fact that so-and-so has mental illness and blame that for it, as opposed to figuring, okay, why are they making the threat in the first place? It's not like there's a magic pill to make threatening behavior go away. You know, what is it that's driving this behavior? You know, if someone is saying that they're going to kill themselves, yes, that has to be taken seriously. It's not saying that the school shouldn't, but why are they saying that? You know, what is it that's driving that? You know, if it's frustration with what? You know, what is it? So you want to treat the underlying issue. You want to get at what is it that's driving the frustration? Is it that, oh, yeah, they're depressed. Okay, then I can treat the depression with medication, with therapy. If it's a situation with the kids at school, if it is the bullying, because the awesome anti-bullying policy, that just means that you've developed a better bully. They just do it when you don't see. So if there is that bullying situation, okay, what can we do in terms of teaching social skills, in terms of getting you out of the situations where you're near the bully? It's difficult, not saying it's going to be easy, but you want to try and address that. Give them the tools to deal with that particular situation. So you're more likely going to erase that particular source of threat. So not an easy answer, but it's not an easy question either.
What can you do for the aggressiveness, the autism, the meltdowns?
Okay, that's the part where medication comes in.
Okay.
You know, all this about this stuff that's not medication. Yeah, aggression, okay, that's where we've got medications. That they've done a number of studies for aggression, both on and off the spectrum, and that's usually coming down to the antipsychotics or the mood stabilizers. And there's, you know, different studies, and you can rank them as to what's more efficacious and what's not. Sometimes it comes down to the individual chemistry and what they respond to best. But that's where the studies came into for the Risperdal and the Abilify, where we have the FDA approval. The irritability in autism, yeah, that's not just being irritable, but that's also being aggressive too. And that has been studied for kids that are off the spectrum for aggression. And it's usually much smaller doses than mood stabilizer or antipsychotic doses. And with very young kids, that also means sometimes multiple times a day in advance of when they're getting aggressive. You know, some kids, there really seems to be almost like a witching hour. Evenings are horrible. Okay, so if they're having a meltdown every day at like 6, 7 o'clock, 5 o'clock, there we go. So that way it has time to get into their system, kick in, and reduce that irritability before it even happens.
Have you ever heard of a child on the spectrum that was obsessed with, like, this is a personal experience, a child that's obsessed with another child? Like, when my son goes to school, there's this one kid that it makes his anxiety so high when he sees this kid that, like, my son, he does talk a little bit, but, like, when he sees that kid, his day is ruined. He, like, loses his mind, wants to attack this child. He doesn't have, he can talk and, like, say if he had a good day. You know, he's starting to get his vocabulary together. We have no idea what this child did or what happened. And the school says he's a perfectly nice kid. They don't know why.
He may not have done anything.
Well, that's just it. He goes after him. And then for, like, the kid was sick for a week. And my son was like a different child the whole week. Like, he was happy at school. He had a great week. When he came home, he was he's in therapy. He had great sessions. This kid, like, he's obsessed with it. Like, he talks about him. He's like, during the music, we'll change names. Where is John? You know, where's John? What's John doing? When he gets home, he, like, you know, when he writes at school, he writes about John. And, like, but it's like when he sees John, he's, like, filled with rage.
And it's something like that, to address that with medication, I would take it more as almost like OCD, because that's that obsession with this particular thing. It happens to be a child, but there's that obsessive thought, that constant, over and over and over. And the compulsive part would be the writing of the stuff, the asking over and over and over. There's that preoccupation, that intrusive kind of thought. So if we treat it as if it's OCD, that would be the SSRIs.
Because there's other things he's obsessed with too.
So it might reduce that too, but
this is actually affecting his school day, and it's affecting the way, like he would be fine, like, in his classroom to, like, travel outside the classroom by himself, because he's very smart and he can do things on his own. He's very high functioning. But this kid, they never know if he sees him, if he's gonna lose his mind, and, you know. And he's not like that any other time, you know, like, he doesn't attack his brothers or me, or once in a while, I shouldn't say that, he might get mad or something, but so is my 11-year-old who's not on the spectrum, so.
In a case like that, would you delve into it to try to go back and
if
find out
he's
history?
verbal
If there's
enough
some
and aware enough,
altercation?
he may not be aware enough to be able to say, and if we don't have enough from the teachers or any paraprofessionals, we may not know exactly what happened. And it could be something that the adults did see but would totally dismiss. You know, maybe it was something where this other kid, John, didn't wave at him, but waves at the kid next to him.
That's what I kind of think it is.
You know, if it's something like that, the adults are never going to see it, because they're looking for, oh, was he bullying, was he pushing and shoving, or did he throw something at your son or something? But if it was something like that, it was just the, oh, hi, Max. And then your kid is over here, I hate you now. If that's what it is, teachers are not going to pick that up. But if that's enough to kind of feel the more obsessive thinking, that's the part that we would get at.
I think he's very aware of things, but he can't get them out. He's very, he understands everything, but
He just doesn't have the expressive language.
Yes.
And that has to be taught.
Yeah, I mean, he learns some, but I mean, he talks like he'll use, like, books, like, things to say things that he wants to tell you, but.
Because it's very scripted.
Yeah.
The language that he has is very scripted.
But yeah, I feel so bad because this is really holding him back in his school day. I mean, he is a very bright boy and he could make so much progress, but it's just these little things that he gets obsessed about or anxious about, they're just holding him back.
So something like that would be a case where, yeah, that's where we would have a discussion about medication, because it's interacting with his ability to function at school. Because even when he comes home, it's still interacting with his day. It's still interfering with his ability to do therapy.
He even like sometimes it's so weird because I feel like single white male. He like will write like John like as his name, like when he signs into the iPad for a while. And I thought like maybe he just really wants to be friends with this kid, and maybe it went wrong. But no, he gets angry when he sees him. But then he like I think something like what you said. I think is what happened that one day he showed attention to somebody else, and then it just
spiraled from there.
yeah, and it's really affecting his life. Is what I have.
And we may not know any specific thing. Like, it could be very, very little. Like the number on the bus example that I mentioned earlier.
Yeah, that happened to him too.
Well, I mentioned that because that happened with one of my patients where we only figured that out 3 months later. We had no idea at the time what happened. Oh my God.
My son doesn't like it when the car runs in the wintertime, and all last year we would like, turn off JFH, and like my other 2 kids were going nuts. They're like, Mom, I don't want to get into a cold car. What is JFH? And finally one day my ex-husband goes, it's the letters on your license plate. JFH needs to turn off. I didn't want to get into the running car. I didn't even know what the letters on my license were.
But this is how literal.
They could be over the loudspeaker at the store. Somebody has their headlights on and keep shouting. I have no idea.
But this is how literal they can be. So that's where it makes a difference. You would see somebody like me when it's actively interfering with how they can function during the day.
Well, then I'm calling my insurance
Get on the list.
I got a question. So share with us one of your success stories where therapy has helped and child has excelled or gained confidence in something.
Actually, my favorite one was actually the same kid with the bus. It was actually during my training. And I list this as one of my successes because actually periodically I still write to the mom back and forth. We keep up, so I know how he's doing even though I've been out here 4.5 years. And started off with a lot of aggression and could not really function well at home, was getting into these humongous meltdowns that were lasting 2 hours at a clip. And he would throw things, hit the wall, he would hit his mom, his grandmother, and mom has her own medical issues, like she has sickle cell. And so a couple times it threw her into a crisis. So it's a serious deal when he had one of these ginormous meltdowns. And it was more than what she could handle or what her mom could handle too. And in New York State they have an alternative school system. So it's called the BOCES system. So it's kind of like the alternative high school that's here in Manitowoc, but it's elementary school, middle school, and high school, and they come out graduating with a high school diploma. So he was getting evaluated to go in there, and as part of that process, they also recommended an evaluation with the training clinic where I was at. So I was the second fellow to see him by a couple months. He started with the fellow behind before when I took over. So he was started on Abilify 2 milligrams at the time because he was 7 or 8 at the time. And that didn't really seem to do so well with the other fellow that he was working with. And so I talked with the mom, okay, since it seems to do absolutely nothing. 2 milligrams is a small dose, but she wasn't sure if she saw even a little something in order to kind of justify playing around with the milligrams. We swapped over to Risperdal. No, that was not good. That right away she could tell, no, that was no, just no. Like phone calls within the week, no. So we said, okay, in retrospect, maybe the Abilify was doing something. So we went back to the 2 milligrams, and she paid a little bit more attention during the day on weekends and tried to get reports from the teachers when he started the BOCES program. And that was easier to get information from than his prior teacher, because New York. Everyone's talking about how their classes here have a lot of kids at 20, 22 kids. Yeah. Okay, I'm a product of New York City Board of Education. I was a good year if I had 35 kids in my class. So he was in the same situation with his public school. So with that, his regular teacher couldn't really pay attention, but in BOCES, they had about 15, 16 tops. So the teacher would actually track what his behaviors were like during the day. So he got the Abilify in the morning, and by about 1 or 2 o'clock, he was starting to get more rowdy and irritable and just mouthing off at the teacher and repeating huge, huge chunks of movies the entire time. And of course, they were not appropriate movies either. It's never the appropriate movies. So, because we got a couple phone calls from the school, and it turns out that, like, yeah, Mom watched the movie Roots. He repeated a huge chunk from the middle of that movie in the middle of class. So, yeah, that didn't go over very well. But, so, okay, so 1 o'clock, 2 o'clock is that time for them. Okay, we had morning, we had noon. So we started with that 2 milligrams twice a day. And his older sister had cognitive disabilities too. And she had some sort of bullying at school, and then she was acting out at home, and that would set him off in the evenings, and so we had to do 3 times a day to kind of limit how things were going, because Mom couldn't keep both of them from going off the handle. And over time, like, that held things for about a year or 2. He was growing at the same time. And so around the time before I left that clinic, we wound up restructuring a little bit. He was on 5 milligrams twice a day. Like, we had gone gradually, because with the 3 times a day and then an additional 2 milligrams as needed. So by the time I left, he was on 5 milligrams twice a day. I kept up with the mom, and so over the past 4.5 years, he's still on Abilify. It is, what is it? I think she told me how much it was. It wasn't changed that much from when I left. He's still on the Abilify. I want to say it's either 10 or 15 milligrams. He's still in the BOCES program. He's like what they consider honors there. Doing great, none of the repetition. He's very socially outgoing. He loves the social skills groups that they've got him in. He's been going for swimming classes at the Y. He's been wanting to go out and learn new things. That there's been absolutely no aggression whatsoever. They've been even talking about mainstreaming him, the last letter she sent me. So, and he still asks about me every once in a while. No, I mean, he was such a cute kid. I mean, it's one of those things, it's kind of weird. One of my colleagues referred to me a bunch of her patients, some of which were autistic and violent, and I was like, what are you talking about? They're fine. They have a great time together. Yeah, it doesn't bother me.
I want to go back to aggression just a little bit. From your point of view, is there ever a case where they'll come in and they're like, my child's aggressive, I need medication, that you say, this can be handled, this is a lack of communication. If you do this, you don't need meds.
I've actually sent people out of my office without any scripts. Not too often, to be perfectly honest, because by the time people get to me, they've kind of gone through the pediatrician, they've gone through a therapist or something like that. So odds aren't good that people are walking out without a script, but I've done it. Where it's like, no, I don't think that I have a medication for you. I don't think this is something medication will address. I think you can go deal with this with a therapist. It's pretty mild. Or it's one of those things where I'm on the fence, where I don't have that sense that we have to treat this with medication. We can take the slow route if you're willing to deal with it for a while and work on it through therapy. Not necessarily aggression in general, because usually when it's aggression, they're talking about like getting beat up back and forth, or usually I try not to see kids that are below 5. Sometimes the pediatricians will refer before that because it's bad. Like one of the ones, but another one of my favorite ones, although he's not on the spectrum, but 3.5 years old and broke his sister's arm. So, yeah. Right now though, actually it turned out I was the one that pointed out to the mom, do you have problems understanding his speech? And she's looking at me going, what are you talking about? because she's with him all day long, she didn't notice he had expressive speech problems. And so I got him hooked in with, and said, go to Riverview, get the speech language. So he's been in speech. He got into Head Start with there. He's been there. He's in kindergarten this year now. I mean, a lot of his symptoms did result into ADHD, but it's been fantastic. He's on really scary doses of things. We've managed to peel him off a lot of stuff, but like I started with clonidine for him, and to look at his methods, it's like, wow, you're on that much clonidine and you're walking around. Oh, like if I hadn't gone slowly, I would, yeah. Like the pharmacist every once in a while would say to the mom, you do realize there's 2 of these scripts here? Yes, I know. Yes, the doctor knows. Because it's, wait, you're on how much? And you're how old? Because he's 5.5 now. But his speech is so much better. There's been, other than the 5-year-old outbursts, but there's been none of the aggression at his sister. He's not pulling out his mother's hair anymore. He's not pushing anybody down the stairs. All that's gone.
And is that something, do you think that, you have to treat it initially, so if the medication helps, but then let's say they have therapy as well, is that something you could kind of wean off and see if maybe just the structure of the routine or helping him with his expressive language or something helps too?
That's what we've done, because he's not on just clonidine, but that's what I started with.
Okay.
3.5. I'm not gonna. No. And actually, my reaction is what made the mom come back to talk about it, because even at the initial response, I was like, your child is 3.5. I do not want to give him anything heavy duty. He's a little, okay, no, he was not little. He's a really solid chunky little boy. But I mean, he's little in age. I don't want to do that. He's still developing. But we have to treat the aggression because he had broken his sister's arm at that point. And so I said, I want to take the least amount of medication, the least amount of side effects, because he's 3.5. And that's why we'd gone with clonidine, which did not sedate him at all. But that wasn't quite enough, even at the scary, oh my God, doses that, no, his vitals are fine. Vitals are fine, doesn't sedate him at all. But it wasn't enough. He was still getting aggressive. I did have to put in Risperdal. And that knocked everything down. He wasn't aggressive anymore. And then with the schooling and the structure and the speech therapy, they were the ones that really confirmed the hyperactivity that we had talked about, that the clonidine probably will help that too. It didn't help enough. But we were able to get him off the Risperdal. So he's off the Risperdal. Mom's scared to come off the clonidine, but that'll be the next to go. I just saw him a couple weeks ago, actually, because after the school starts, we want to make sure it's still working well enough for school. He's doing great at school. He's doing great at home. And she wants to leave things through for the school year, but if the school year still goes well, probably over the summer, we'll start to cut out some of that. Because that's usually a safer time to come off medication anyway. It's a lot less stressful over summer. Yeah, and especially for like anything food related, I try not to mess with things over winter.
Actually, I was going to say, I think we'll wrap up officially for the meeting, so I do thank you again.
Thank you for listening.
Yes, again, this is from Holy Family Memorial Behavioral Health now, Dr. Mylan Kohler, so thank you for being here.
You're very welcome.